So good morning. It's officially afternoon. It's now noon. So we're going to start this next session on a dancer's guide to women's health and cancer. So it's a pleasure to introduce Emilie Mathura, who is a second-year osteopathic medical student in Denver at Rocky Vista University. So it's a little earlier there. So thank you for getting up early. So Emilie is interested in women's health issues and ultimately wants to have a career as an OBGYN. So outside of school, we all know Emilie as a dancer. She now dances with the Denver's Yamulee franchise team and Delia Madura's virtual Zuberi team. So you'll either find her in the classroom or in the autopsy suite, I guess, or on the dance floor. So for today's presentation, Emilie planned a fun and highly interactive session where she's going to review the major cancers that can affect women and ways that women can prevent those cancers. She'll cover things like self-screening and why some cancers affect women specifically. And she'll also discuss at the end the intersection between women's health and dance and introduce some useful tools that women can use to stay safe and healthy as a dancer. So without further ado, let me turn the presentation over to Emilie. Thank you.
Hello, everybody. It's really awesome to be here as part of Baila Cura. This is such a great cause, and I'm really proud of Matt and the community and the Raleigh-Durham area who are putting this on. So thank you, everybody, for joining. We're really excited. We're going to get the presentation started in about a couple minutes. We just want to wait for people to have time to join. So Daryl and I will just be chatting.
Yeah, so what was it like to transition from being a post-bac at NIH to actually having to go back to the books and study?
That's a great question. Med school is insane, but it's been the most amazing experience because finally I feel like I get to learn all the things and do all the things that I've wanted to do for my whole life. So it's been really exciting. Definitely challenging, though, I will say.
So you may or may not want to answer this question. So what's the dance community like in Denver compared to the Triangle in North Carolina? Is it as good or better or not as good?
I think it's just different. I think there's a much bigger emphasis here on social dancing, which is really fun and great for someone who is in med school because there's not a lot of time to train. And I would say in Raleigh-Durham area, there's a huge emphasis on training. I'm also, hey, Austin. I'm also pretty new to the scene. I've only been here for a year and in reality haven't been able to dance as much as I have in other places because of school. So that's my beginner's dancer's guide to Denver.
So how hard was first year of medical school? Was it as hard as you expected or not as hard?
It was way harder. It was so hard.
How many all-nighters did you pull?
That's one thing I did leave in college. All-nighters don't really work in med school because you can't remember anything when you don't sleep. But I have definitely spent many days from sun up to sundown at my desk, hunched over my computer.
Yeah, well, it'll get better when you start doing the clinical rotations. You'll have more, and you'll actually lose more sleep because you'll be up all night taking care of patients, but it'll be a lot more enjoyable. I think you'll really like that as you start getting more clinically oriented. Patrick says hi. Hey, Patrick. So we're gonna hopefully Matt will get the slides going. I see them now, and you can start whenever it's convenient for you.
Okay, awesome. Well, welcome everybody, and I'm really excited to talk to you all about cancer and women's health. As we mentioned before, I'm Emilie Mathura, and I'm a second year at Rocky Vista. Next slide. So I just wanted to give you guys a little bit of a background about me and dance and medicine so you can understand how these two worlds kind of collide for me. So then you'll understand more about where I'm coming from with my presentation. So as a dancer, I started in the Triangle area with the Cobra Brothers. I actually danced before that in college, but then once I joined the Cobra Brothers, I really fell in love with dance and I wanted to really put my all into dancing. So I was there for about 6 months before I moved to Atlanta, where all these pictures are from. This is where I was on Paso Fino, and I really got to enjoy the Congress scene and get to travel around and be a part of a dance company, which was awesome. And now I'm a part of Colorado New Style in Denver, where we have the Yamulee franchise team. And that's been a really great way to relieve stress from med school. So one other plug I want to make is that salsa over bachata every single day. That's me as a dancer. And also for my medical background. So I'm an osteopathic medical student, second year at RVU, like we've said a few times. And as Dr. Zeldin mentioned, I am very interested in women's health and OBGYN, which is why I'm giving this presentation today. So you may be wondering, what is osteopathic medicine? And I won't give you a huge lecture on it. I just want you to know that if you do have questions about what's the difference between osteopathic and allopathic medicine, you can definitely reach out to me. I love being an osteopathic medical student. I think we get to learn a lot of really awesome things. And the main difference is that on top of all of the medical curriculum that we get, we also get to learn about how the structure of the skeletal system and the muscular system can affect the organs in the rest of the body. So we really believe that the body is a functional unit that can be affected by everything that's happening in the body. It all affects itself. So that's kind of a little underpinning of my philosophy on medicine and where this presentation is coming from. So we're going to start out with a quick anatomy lesson, because in order to understand cancer, we have to understand where it's actually happening. So we'll start with the female reproductive system. And I really like this picture because it shows us where in the body this is sitting. So here's the interactive osteopathic part. I want everyone to put their hands on their hips, and I want you to move down until you feel this really hard bone. So that's the pelvic brim, which is at the top of this picture where the belly button is. If you follow the horizontal line, you can see that faded pelvic brim. If you follow the pelvic brim down, you can feel the pubic symphysis, which if you follow the hard bones towards the center, towards the entrance of where the vagina would be, that's where you can feel the pubic symphysis. And right above that is where the uterus sits and where all this anatomy that we're going to be talking about today is actually sitting. Next slide. I like this picture because it's really cute and cartoony. So I'm going to explain the anatomy on this one. So as you can see from the bottom, that's where the vagina is. So the entrance to all this beautiful female reproductive anatomy starts there at the vagina. And everyone kind of knows where that is. So I like to start there. And then as we move up, it kind of looks like a man who's flexing his arms. And where his body would be is called the uterus. And this is where the baby is actually going to be growing during pregnancy. And the door between the vagina and the uterus is called the cervix. And so these are some key players in women's health cancers that we're going to be talking about later. So from there, as we move out towards the arms of this flexing man, this is called the fallopian tubes. And those tubes are what I call the obstacle course for the semen. So they have to jump through a lot of hoops to get to the eggs and actually fertilize them. So they'll travel through those fallopian tubes, and fertilization actually usually occurs there. But the egg is released from the ovary. So if you follow the fallopian tube down to that circular organ, it's called the ovary, and as you can see, that's where the eggs are maturing, and that's what those little circles are inside of the ovary. So another part of the female anatomy that we need to talk about, because breast cancer is so prevalent, is the breast. So everyone knows this front view, but we really need to look inside of the breast to understand how cancer will work inside of it. So we're going to take the breast and we're going to cut from the collarbone down and cut it in half. So now we're seeing a cross section of the breast where we can see the fatty tissue, which everyone obviously assumes is inside of there because of the way it feels. But then there's also some great organs working in there as well. So you can see the lobes and the ducts, which is where milk is going to be made and then produced and ultimately expressed through the nipple. Next slide. Okay, cool. So now we're going to move on to the female reproductive tract cancers, now that we understand the anatomy. And number one, second to skin cancer, is breast cancer. So 1 in 8 women will develop an invasive breast cancer throughout their lifetime. So I'm sure each of you have a story of someone you know, or if even a family member, or maybe yourself, who's been affected by breast cancer, which is why this is the one I'm going to spend the most time on, because I think it's very prevalent and something we should talk about screening and self-screening for. So how does this start? There's many different things that will influence your risk factors for breast cancer. And the first is genetics. So we want to talk about BRCA1 and BRCA2, which you guys may have heard of because they're very commonly mentioned in the doctor's office. And these are the most common gene mutations for breast cancer. And so because there's such a huge genetic component, the family history is also really important. So if you have a first degree relative with breast cancer, the risk increases twofold. And what first degree means is a mother, a daughter, or a sister that has breast cancer. And so like we talked about before with the ducts and the lobes, this Cancer often starts in the ductal tissue, but it can start in any of the cells in the breast. And then the way that it spreads is that abnormal cell will mutate out of control and cause spread. And if you want to know more about that, Florencia is going to be doing an amazing talk later today. She'll talk all about how how the cell turns cancerous and then spreads throughout the body. So I definitely recommend that talk. So let's talk about how it spreads. So we have some major highways in the body that the cancer can be using to move around. And that's what when we're talking about metastasizing, that's what's happening. So one way that it can spread is just growing bigger, and that's tissue spread. Another way is it can use the blood vessels. If the cancer cells get into the blood vessels, it becomes this major highway system to many parts of the body. And as this diagram is showing, it can go to the brain, the lungs, the liver, and the bone is where it most commonly metastasizes to. And then the other way that it can travel around the body is through the lymph. And that is another lower pressure circulatory system that we have in the body that's useful in immunology. So next we're going to talk about screening. So this is the most important thing for dancers, is we need to know how to screen for these things and how to protect ourselves. So the mammogram, as many of you know, and I hope you guys enjoy this funny cartoon, the mammogram is the best way that we screen for breast cancer. And what this is basically just an x-ray of the breast. And as you can see in the picture, we kind of smash the breast into this x-ray machine so that we can see all of the tissues laid out in the breast. The other great thing, or another great tool for screening for breast cancer, is breast self-awareness. So we're gonna learn a little bit from our favorite dancers about how to do a breast self-exam. So we'll start out with Ernesto and Denise, and we'll take a good look. So you just want to walk into the bathroom, take off your clothes, and just look at yourself in the mirror and look at your breast tissue. How does it look? Does it look like it did yesterday or 3 years ago? And it's okay if it changes over time. What we're really looking for here is lumps, swelling, redness, nodules. And then once you've taken a look and you've seen how things are looking, you're going to go to step 2 with Franklin Diaz and raise your arms, and you're going to look again. Because when we raise our arms, we're able to see the bottom part of the breast tissue that we may not have seen while our arms were down. So then next, we'll go to Eddie Torres and Maria Torres, and you're going to lay down, and we're going to keep going with the self-breast exam. And this is the most important part. So on the next slide, we will see how we actually perform the self-breast exam after we've done the inspection part. So I like the method in the middle, which I call the lawnmower method. And you're going to start from that collarbone that we mentioned before. You're just going to walk your fingers up and down in a lawnmower pattern. So you're feeling all of your breast tissue down to the ribs. And what you're feeling for, again, is those nodules or any swelling, tenderness. And the best time to do this is about 3 to 5 days after the menstrual cycle has ended or your period ends, because that's when a lot of the tenderness that is associated with your period is usually over. So now we're going to talk about endometrial cancer, and this is number 2. So 3% of women will develop endometrial cancer during their lifetime. Next slide. So how does this one start? I'm sure you're wondering, what is the endometrium? Because we didn't talk about where exactly this one is. So we're going to go back to the uterus, which, if we're going back to the analogy of the man flexing, it's his body. That's where the baby is growing during pregnancy. And on the inside, the lining is the endometrium. And this is what's actually going to be growing and sloughing off when you get your period and you experience bleeding. That's what you're actually seeing coming out. So there's 2 major types, and that's type 1, which is estrogen mediated and linked to obesity and estrogen excess. This can happen in younger women. And then type 2, which is associated with older women and usually leaner women. And this one isn't as linked to estrogen excess. But it can arise from any cell type in the endometrium, as we'll see on the next slide. So there are no routine tests for endometrial cancer, which compared to the other ones seems kind of strange. We usually are screening for a lot of these reproductive health cancers, but because this one presents a little more obviously with vaginal bleeding that's not associated with your period, it's a little bit easier to detect in that way without doing the screening exam. Once we see vaginal bleeding, we can go a little further by doing a transvaginal ultrasound, which basically means we take a stick, put a camera on it, and put it into the vagina, and so we can see everything that's happening above the vagina. And this helps us see lumps or masses or things that may not look right, And if we see something that doesn't look right, then we can go ahead and biopsy, which means that we'll take a tiny instrument and scrape off some cells from the inside of the uterus, and that will be able to tell us much more about what's going on inside of the uterus and the endometrium. So then how do we treat it? This one is treated with surgery. So these blue boxes are showing how much of the uterus or the female reproductive tract is being taken out. And all three of these procedures are used in endometrial cancer treatment. The higher the grade may require chemotherapy and radiation. And I think Florencia or another talk today will talk more about grading and what that really means. And a lot of women ask, well, what if I want to have a baby first before I remove my uterus? Because like we said, this is where the baby is growing. It's totally possible. And the way that works is through progesterone treatment. So if this happens, you're always able to talk to your doctor about those other options. Survival rates are actually when they're caught early, are pretty high at 81%, which is why surgery is used, even though it's pretty invasive. So number 3 is cervical cancer. And this is probably the one that a lot of people have interacted with in terms of the screening test. So we'll talk about that in a few slides, but 0.6% of women will develop cervical cancer during their lifetime. So as you can see, the prevalence of this one is much lower than the first two, but that doesn't mean that it doesn't affect people. It's still prevalent. So how does this one start? This one is pretty interesting because it's linked with the HPV, or the human papilloma virus. So it's one of the cancers that's linked with viral chronic infection. So HPV is an STI, as most people maybe know, and it can be prevented with Gardasil, which is a vaccine that the CDC recommends for children from 9 to 12. But if you haven't gotten it when you were 9 to 12, you can still get it later in life. So I want to talk a little bit about where the cervix is and how this is actually looking on the cervix. So again, we're going to enter through the vagina, like on this picture, and look up. And what we'll see is the diagram on the top, which looks like a little donut. And that's kind of how the cervix looks normally. And so what a pap smear is the way that we screen for this. And we'll talk about this more on the next slide. But when the cervix becomes inflamed or cancerous, we can test those cells by swabbing, which is what this picture is showing, a little swab going in a circle. And that's the pap smear, which will take cells out of that area. We can put them on a slide and take a look at them under the microscope and see what's actually going on. I also wanted to mention that HPV is pretty prevalent at 45.2%. A lot of people are worried about an abnormal pap smear, but there's a huge percentage of the population that this happens to. Okay, so how do we find it? I talked about this a little bit already, but the pap smear test is really important. This is the one where the doctor says, can you scoot down a little further on the table when you're already naked and feeling really weird at the doctor? We have to do this test. So if you have an abnormal pap smear, what happens next? And the good news is that many low-grade changes tend to resolve within 12 to 18 months. So usually your doctor will say, let's wait a year and we'll retest. And many times it goes away, which is awesome. But it also depends on the results. So always follow your doctor's advice about how to proceed based on your results. So how do we prevent it? Like I already mentioned, Gardasil is super important here, but like this picture mentions, we need to cover your wiener and safe sex is super important. So I really like to preach in this section that teaching our children and practicing safe sex practices and normalizing that is super important in preventing cancer. So just to talk a little bit about the schedule, if you're between 21 and 29, you'll need to be screened every 3 years, but after 30, then you can change to every 5 years. Okay, so the last and final cancer that we'll be talking about is ovarian cancer, and that's cancer number 4. And 1 in 78 women will develop ovarian cancer through their lifetime. So compared to breast cancer, which is 1 in 8, 1 in 78 doesn't seem like a lot, but it still does affect people since this is the number 4 women's reproductive health cancer that is experienced in the population. So what is ovarian cancer? We talked a little bit about where the ovaries were, but we're going to follow them again from entering the vagina, then you're in the uterus, go out the fallopian tubes, and then you're in the ovaries. And this, like I said, again, is where the eggs are maturing and being released during ovulation. And the ovarian cancer can come from 3 types of tissues. So there's the epithelial cells, which if you think about the ovary as an egg, the eggshell would be where the epithelial epithelial cells are on the outside. And then it can also come from germ cells, and these are the cells that actually produce the eggs. And then lastly, it can come from the stromal cells, which is kind of all the connective tissue that's holding all that ovary together. So how do we detect this one? So again, we're going to use the pelvic exam, which is the one where the doctor will insert their fingers into the vagina and actually feel the size of the organs. This one's pretty useful because we can feel what normal feels like. So when we feel around and we feel something abnormal, it allows us to say, okay, we need to go further and more testing. However, because there's a lot of tissue in this area, sometimes it's hard to feel things. So we also use the transvaginal ultrasound, like I mentioned before, where we're just going to put a camera on a stick, insert it in the vagina, and take a look at everything that's going on inside. Another interesting thing about ovarian cancer is that it's also linked to the BRCA gene. So people who have a mutation in the BRCA gene have about a 50 to 85% breast cancer risk, but they also have a 40 to 60% ovarian cancer risk. So it's really important to screen for both of these when we see a BRCA cell mutation or a BRCA gene mutation. Next slide. So how do we prevent it? I thought this was really interesting, but one way that we can lower the risk is pregnancy. So people who are pregnant before the age of 26 and every pregnancy after that actually lowers their risk for ovarian cancer. However, I wouldn't recommend getting pregnant just to lower your risk for ovarian cancer. As you can see, this monkey is maybe not enjoying it as much as she thought she would. The other thing that we can do is birth control pills and tubal ligation. Again, we wouldn't use tubal ligation, which means tying tubes, if you've ever heard someone say that phrase, or hysterectomy, which is where we remove the uterus to actually prevent ovarian cancer. But it just means that people who do have these procedures for other reasons may have a lower risk of ovarian cancer. Next slide. Okay, so I wanted to end with some myths about women's health cancer before we go into questions, and just talk about two myths that I was curious about when I was preparing this presentation and that you may be wondering as well. So there's been a big push for removing aluminum from deodorants because of its link to breast cancer. And there were some studies that may have indicated that. But as of right now, the American Cancer Society has busted that myth and says that there's no real link in the data about aluminum and breast cancer. That doesn't mean that it doesn't exist, but it hasn't been completely proven quite yet. Next is that getting HPV is rare. And I wanted to bust this one because I've had a lot of people reach out to me and say, I had an abnormal PEP, what does this mean? But it's not super rare. It's actually the most common STI in the US, according to the CDC. So I wanted to ease some minds there. And with that, that's all that I have for you guys so far. So if you have any questions, I would love to move into the question and answer part of the presentation. And I'm going to invite Daryl back on the screen.
There we go. Hopefully you can see me and hear me. That's a great presentation. So as the audience is going to start typing in questions, it'll be posted. Let me just start with a question about birth control pills. So, there's a lot of controversy out there about the role of birth control pills, estrogens, and breast cancer and ovarian cancer. So is it safe for women who have no family history of breast cancer to take birth control pills? And how about women with family history of breast cancer and ovarian cancer?
I'm not able to speak to if people have a breast cancer risk that they're worried about and taking birth control pills. I would definitely need to check up on that. But I will say that if you don't have any risk, it is definitely safe to take birth control pills. And that's definitely something that you can talk about with your OBGYN and discuss your personal risk and talk more about what's the best method of contraception for you, because there's many options besides birth control pills that may fit a little better.
Right. That's a great suggestion. For all these issues, I mean, you're best to talk with your primary care doctor or your OBGYN and just ask them what best to do. So how often should women get screenings for breast cancer? How often should they do self-exams, and how often should they get the mammograms? And does it depend on how old they are?
Yeah, so that's a great question and a pretty loaded one. And I'll also address Susy Lopez's question as well. which she says, how often should I see a gynecologist, which kind of works into this question really well. So the gynecologist that's something that's up to you, but generally once a year is what we suggest. And that doesn't mean that you have to get all of the screenings every time you go. It just means that we can check up as long as you're coming consistently. Your doctor will have a better idea about how your reproductive health is going. So for the mammograms, I think it's every 3 to 5 years. We can reference the slides. And then the pap smear is every 3 years if you're under 30, and every 5 years if you're over 30.
And you do that more frequently if you have increased risk as well. Like if you have a family history, or right, you're going to do the pap smears more often than every 3.
So once you get an abnormal pap smear, you're going to probably do it once a year until they resolve, and then your OBGYN can decide from there how often you want to screen after that. But yeah, it can change. With a higher risk, you obviously want to screen more often just to keep an eye on what's going on.
Okay, let's see. Are there any more questions in the chat box or in the? So do I have to see a gynecologist for women's health, or can my primary care doctor take care of that? That's a good question.
Yeah, that's a great question, because I think adding specialists definitely complicates medical care. So you don't have to see a gynecologist. There are plenty of primary care doctors who have gone through the little bit of extra training to understand how to do pap smears, and they can definitely complete that for you in your primary care visits. It just depends on what your primary care doctor is able to do. So I would just call them and ask them, hey, is this something I can get done at the office? And generally they'll have someone on site who can do it. But if you don't find that at your office, I'm sure there's someone nearby that definitely can do primary care and the women's health well woman exam.
Yeah, that's a good point, because not everybody has access to a gynecologist, particularly in rural areas and in other parts of the country.
Absolutely.
Okay. More questions on the chat?
How do they add a question?
I think I should point that out. So they can add a question either on Facebook, just add it into the comments, or if they're watching on YouTube, you can just go to the right and there's a question and answer. And I think let's see here, that doesn't tell you how to add the questions, but yeah, there are easy ways to add the questions on either YouTube or on Facebook. Write them in the comments below, it says. Yeah, so there's a comment section on YouTube. So other questions? There's a little bit of a delay in getting them to show up because they ask, and then Matt has to enter them onto the screen. And
don't be shy.
Yeah, don't be shy. We have a bunch of people watching live, so there should be a bunch of things that come up. Did you get the Gardasil vaccine yourself?
I did, yeah.
So they don't give it to older people, though, right? I mean, there's a certain age limit, I think, where that's advised, right? Women over, what's it, 50 or something shouldn't get it, or
over 15, you said?
Maybe it's a little younger. I have to go back and look. But.
I know it's scheduled for between 9 to 12, like those middle school vaccines. But I read when I was researching for this presentation that you can actually get it later, and as long as you're sexually active and you want to get it, I think as a later adult you can still get it. I'm not quite sure on that though. I'll double check.
Yeah, it's covered by insurance, as are most cancer preventions, and it's a really, my daughter got it, and it's a really good thing to get. It's one of the few vaccines that can actually prevent a common female cancer from occurring. So while we're waiting for scientific or medical questions, so why did you decide to become a physician?
That's a great question. I sometimes ask myself that a lot in med school because it's hard. But I just truly love medicine. Like, that sounds really nerdy, but I love it. Every day I'm in lecture and we're learning about these amazing, cool, beautiful things that anatomy and physiology gets to do. And it's awesome. But on top of that, there's another layer of wanting to care for people and wanting to spend my career working with people and talking to people about their problems. So it allows me to mix science and my love of working with people together. And then why physician over nurse or something else like that? I think physicians have a unique role in healthcare right now, especially as we're facing a lot of challenges in healthcare, that they get to be leaders, and leaders are allowed to create change in a system. So I because of that perspective and that responsibility that physicians have, that's one reason why I decided to go to medical school instead of other parts of medicine, which are equally awesome and helpful in care of a patient.
And why women's health? Why OBGYN? What was it about that attracted you to that field?
I took a women's health and science and technology class in college, and I learned about the history of gynecology and how it was mostly written by men, which was awesome at the time. Like, it was great that we had medicine for women, but I think as we move forward, I really wanted to be a part of writing that next portion of history in women's health, which I think will be written by women and for women. And on top of that, I think OBGYN is a really awesome career because you get to do surgery, you get to work in the clinic, you get to deliver babies. So I guess we'll see. I still have 2 more years to figure that out, but
So
that's
have you delivered a baby yet?
I have been at deliveries. I have not yet delivered any real babies, only plastic ones.
Only fake ones. Yeah, the real ones are a little messier, I think. When you,
I heard they're slipperier.
they are a little. You don't want to drop them. You definitely don't want to drop them.
Oh no.
So how many? So you're gonna, if you're gonna go into OBGYN, I mean, so you have 3 more years, right, of medical school, and then you're gonna have to do an internship and residency, and so that's gonna, and then maybe a fellowship if you decide to specialize. So you're going to be like 40 years old before you actually get a real job, right?
Yeah, unfortunately. Sorry, mom and dad.
Yeah, so it's a long road, and I think people sometimes don't appreciate just how hard being a doctor is in terms of the training, and it's long hours. It's lots of being on call, and yeah, it's really challenging. So we got a question from Ruben. Do you know Ruben, by the way? You may know
him.
He asked, is there a booster for HPV vaccine, and does the booster work?
That's honestly something I don't know. Do you know, Dr. Zeldin?
I don't think boosters are recommended. I know the vaccination it's more than one. It's more than one shot, right? You get it at one age, and then at a certain age, and then don't you have to have a second shot for it to be?
Yeah, I think it's a 2 vaccine sort of schedule, but again, I honestly don't know. This is sad.
Yeah, Ruben should check with you before he asks hard questions, especially. Yeah. So here, Susie's asking another question. It says, I have never had an abdominal test, but I'm nervous about cancer because I have a family history of cancer. Does that mean that I'll get it? Yeah.
Okay, this is a great question because I think this is something that's definitely on a lot of people's minds because cancer is becoming something that's prevalent and that we know people who have cancer in our families. But having a family member that has cancer, that really depends on the cancer. So like we saw in breast cancer, there was a really big genetic connection there. So in a cancer like breast cancer, there's a higher risk. That does not mean that you will get it. It just means that your risk goes up and that you should just check with your doctor about how to proceed and how to screen and how to prevent. If you don't have a family member with cancer, it's still important to screen because these mutations, like we'll see in Florencia's presentation, are random. And so they can happen to anyone. So it's really important that we continue to screen and regularly see the doctor for those reasons. And
that's especially important if you have one of the genetic mutations that causes increased risk, like one of the BRCA mutations that you mentioned in your talk. I mean, your chance of getting cancer is really, really high if you have one of those mutations. And so you not only have to get screened often, but sometimes they'll even recommend, some preventative strategies so that you don't actually get cancer. Do we have any other questions? What changes in my lifestyle can I make to help prevent cancer? Great question. Yeah, awesome question. So I don't know if people will like this because this is probably like the common doctor speech, which is sleep, eat well, a lot of green vegetables, antioxidants are a way. I don't know if Florencia will talk about this, but there's a big connection between how antioxidants work and removing these harmful reactive oxygen species from the body, which is something that can cause cancer and mutate DNA. So that's something that you can do in your diet. And then sleep and exercise are really important. Just keeping your body healthy. Like I mentioned in the osteopathic portion, we just want to make our body as put it in the best position to heal and to be healthy.
And the way that we do that is eating well, sleeping, exercise, treat yourself well.
Yeah, that's great. That's great advice for everybody, not just women, for men too. I think exercise, eating well, and living a healthy lifestyle is always really important. Next question from Tobey. So can you speak to the pros and cons of, I guess we're talking about birth control here, IUD versus uterine ablation to help with heavy bleeding? So this is heavy vaginal bleeding, I guess the question is referring to.
Yeah, so I'm going to be honest here, Tobey, and I'll have my email in the next slide. You can email me about this question because I don't know off the top of my head exactly the IUD versus uterine ablation. I will say one pro for an IUD is obviously birth control. So if you're in a reproductive age, having an IUD may control vaginal bleeding, and it also may provide birth control, which is awesome. But there are a lot of risks that come along, maybe not risks, but side effects that come along with the IUD as well, and some people don't like. So it really just depends on what your birth control needs are as to whether or not an IUD would be a good choice for that. As for uterine ablation, maybe Dr. Zeldin, you can talk more about this, but I don't actually know too much about the pros and cons of that, other than I'm pretty sure you'd be destroying uterine tissue, which there are obviously risks and cons to doing that.
Yeah, so the causes of vaginal bleeding, the heavy vaginal bleeding, are typically uterine fibroids, which are really common actually in African American women. And we'll actually hear later from a professor from Harvard who's going to give a talk on health disparities in cancer, and I think she'll probably cover more about this. I think it's at 7:00 tonight. But there are different kinds of IUDs. There are the IUDs that have hormones implanted in them, and that estrogen helps reduce the bleeding. And then there are IUDs that are just more of a physical barrier for birth control. And so if you're going to use IUD to prevent bleeding or reduce bleeding, you're probably going to want to use the one that have the hormones. I don't know a lot about the uterine ablation methods. Again, that's going to be clearly done by an OBGYN. But sometimes just oral birth control pills, just the estrogens that occur in regular over-the-counter birth control pills will reduce bleeding. But again, if you have really heavy bleeding, you probably should see your primary care doc and your OBGYN, and they have a series of tests that they'll do to try to figure out what the causes are and then give you treatments appropriately. So Susie asked another question. If there's one change that I can make today to improve my vaginal and reproductive tract health, what would that be? So what's the kind of the take-home change that you would recommend?
I love this question. I think one thing that you can do is be aware of your body. That's number one. I'm going to give you two because bonus.
It's okay.
Number one is to be aware of your body. That's probably the best thing that you can do is understand what is my body like normally. So then when things start to change or when something's happening that's abnormal, you're able to recognize that. So like we mentioned with the self-breast exam, super important to know what baseline is before you can understand how things are changing, right? The other thing that I will say is one tip for all women is to stop using soaps on your vagina and your vulva that have smelly scents. This is not good for your vagina. So that's one practical take-home tip. Take it out of your shower, throw it away, or just use it on other parts of your body, but not in the vagina.
Right. How about douching? I mean, is that? I guess that this is that. Does that help with anything, or does that?
So this is something that I don't know a lot about the clinical recommendations on douching. What I have learned so far is that douching, again, with scents is not a good idea. With water, maybe okay, but I don't see it highly recommended in what we've learned so far.
Right.
The vagina is this amazing self-cleaning organ, which is why there's a lot of secretion that comes out of it. And that's the way that it keeps itself clean. So when we put stuff into the vagina, we're messing up its natural ability to clean itself.
Right. Okay. Let's see. Maressa, any relationship to you, perhaps? A similar last name. It's not a very common last name.
That's my mom.
From Kris Huckleberry. I don't know who Kris Huckleberry is.
Okay.
If you want to get the BRCA test, can you just ask for it? Or do you have to have increased risk to get it done? In other words, if you go to your OBGYN and say, I want the BRCA test, but there's no increased risk in your family, can you still get it? Or
I think that will depend on the provider if they think that that's something that's necessary. I'm pretty sure you have to have the increased risk that qualifies you for getting the test. But if you were to just walk in and say, hey, I want to get the BRCA test, I don't know why someone might say no. Maybe you know more about that, Dr. Zeldin. I'm not sure.
Yeah, so of course, before you get the BRCA test, you have to think about what you're going to do with the information that you get it, right? So some people maybe don't want to know that they have the gene, right? Because if you have the gene, I mean, you're at very much increased risk for breast cancer and ovarian cancer, and some people may not want to know that. So they have to be prepared to have that information. Mm-hmm. And then, of course, your doctors may recommend some prophylactic treatments that you may not want to do. For example, if you're BRCA positive and you've got a strong family history of breast cancer, they may recommend prophylactic or preventative bilateral mastectomy and taking out the ovaries. And if you're still at an age where you have kids, want to have kids, that may not be a good thing for you. So I always recommend to my patients, before you do these kinds of genetic tests, kind of think and talk with your significant other and your family, and what would you do with the results if the results are positive. I believe nowadays the screening tests don't just test for BRCA1 and 2, but they also test for some other mutations in other genes, other tumor suppressor genes and oncogenes that can lead to increased risk of breast and ovarian cancer. So, but again, your doctor will have all this information. Okay, we have another question in the queue. So from Kelly, I had a 6-pound ovarian cyst. Wow, removed 2 years ago. That's a big cyst. Wow. I had an IUD for heavy periods for 5 years ago. And I've always wondered if this caused it. What are your thoughts?
Ooh, good question. I'm going to say that I really don't know either about if an IUD would cause cysts. I would assume that the IUDs generally there's putting out progestin, and they tend to be they say that it's local, meaning that it's only should be releasing in the uterus. However, there have been side effects to show that maybe isn't true. And there's some kind of like controversy about that right now. I don't think though that maybe actually Dr. Zeldin, you would be able to answer this better about if a higher level of progestin would actually cause a cyst. I'm not quite sure.
Yeah, I mean, they can. Again, I think it's controversial. I think nowadays fewer women are using IUDs for birth control. Most women are using birth control pills or condoms or other simpler methods. And IUDs are not without complications. I mean, separate from the hormonal issues, IUDs can perforate. They can cause, if you get a vaginal infection, they can cause something called pelvic inflammatory disease, which can cause scarring of your fallopian tubes and make it so that you can at some point have difficulties having kids. So yeah, before when women are considering IUDs versus other forms of birth control, or looking for a treatment for bleeding, excessive bleeding, they should really discuss all the potential risks and benefits with their OBGYN, with their family doctor, and make sure they make educated decisions. That 6-pound ovarian cyst may be a record, actually. So Susie asks, how can I help with women's health and cancer, even though I'm not in the medical field, which Susie is not?
Great question. Well, first, by coming to events like this, by being educated and by understanding these sorts of things, that's step one, is to be educated. Step two, you can always donate to lots of organizations that are working to try to find cures, try to further understand women's health and cancers, like by La Cura. They're not working with women's health, but they are working with cancer. So donating to organizations and events like this is already a great way to do that. And those are the two things that I would really suggest for getting started. There are other things you could work at Planned Parenthood or volunteer with Planned Parenthood, or any other organization that's trying to increase accessibility of women's health to general population and people who may not have access to a gynecologist or a specialist.
Yeah, I mean, you mentioned Bilacura, and of course, that's what we're all here today to. So you've been involved in Bilacura over the years when you were in the Triangle, right? I mean, you went to several of the events, and you performed as well, didn't you?
I don't think I've performed at one, have I? No,
but you went to all the dance classes and stuff, and so it's not just about the dancing, though, is it? It's really about the cause and about raising money for cancer research. So is it Is it important to support cancer research, and if so, why?
I think it's important to support cancer research because the more money that we have going into these things, the more, as you know, you can probably speak to really well working at the NIEHS, money is opportunities in research. And unfortunately, sometimes in research, it's just throwing the dart at the dartboard so many times that finally you get it, right? So when it comes to discovering things like cures, where you're working and trying to understand a disease that we don't understand fully, sometimes it's just going to take a lot of research and a lot of time. And in order to do that, we need opportunities. And like I was saying, donations are.
Yeah, absolutely. I mean, I think you're absolutely right. I mean, and just to give an example, I mean, so the BRCA gene, I mean, was discovered at the National Institutes of Health, where I work. Actually, one of my colleagues several years ago was the one who discovered the gene, and that would not have been possible. That discovery would not have been possible without people supporting cancer research, and it saved endless numbers of lives. I mean, it just because people now know that they can prevent the disease, and yeah, I mean, the goal is to fund the research into new treatments, new ways to prevent. And so forth. So that's why it's really important to give, as you point out, to give to organizations like BRCA. So maybe Sabrina or Susan or whoever's behind the scenes can put the website down where you can donate. There are several ways to donate. You can go to to this. It says donate now. You can it's https://bit.ly/32JQZ9R. I have that memorized almost today. So you can be there, or you can also go to the BRCA main website, www.BRCA.org, and there's a donate button there. And today we actually have a number of matching donors. So I don't know if you heard, Emilie, there are several anonymous donors and a couple of named donors who are matching dollar for dollar today. So you give $25, it turns into $50. You give $50, it turns into $100. You give $100, turns into $200. And we have a goal of raising a good amount of money and to be able to give to organizations that support cancer research. And I guess I also need to mention the raffle. So if you donate $50 or more, which again becomes $100 with the matching, you'll be able to be entered into a raffle, and you could win a free ticket to the 2021 gala dinner. And the drawing will be at 9:00 at the end of the day, and hopefully we'll get a lot of people to enter that and win. And I'm hopeful that next year will be beyond COVID and actually be able to get to a point where we can actually have an in-person event.
Yeah, I want to add to that too, that Bailacura has been something that I've loved going to every year. And because there is no hotel, we don't have to pay for travel, we don't have to pay for all the shoes and the glitter and everything. We can put our money into cancer research directly this year, which makes this virtual event kind of special in that way.
Great.
So I would encourage everyone, donate if you can. It's a great cause and a great team behind it.
Great. Do you want to just spend a second and go over your contact information for people who have additional questions that didn't get a chance to get into the chat function?
Yeah, if you have any questions or you want to talk about women's health or anything like that, I am very open to talking to you. Please email me. That's my email right there, emilie.mathura@rvu.edu. You can also reach me at my website. Again, I would love to talk to any and all of you. So feel free to reach out and contact me. I also want to make a quick little plug about my other projects outside of med school and outside of dance. Myself, Ruben Valeriano, and Mario B., who is also hugely involved in Bailacura, are creating Roots, Rhythm, and Soul, which is a podcast that's coming out very soon. And we're really excited to announce that our first guest was Eddie Torres. So it's really cool to interview him, and we're really excited to share that with you guys. Thanks again for coming and for listening. We appreciate you so much, and we're so excited that you're part of Bailacura and everything that we're doing here. Enjoy the dance classes, see the other talks, and thank you so much.
Well, thank you so much, Emilie. You did a great job. And again, there'll be other talks today on cancer. Florencia, I think, will be talking at 2:00, And then I think it's 7 o'clock tonight. We'll have a talk on health disparities in cancer to kind of nail down why certain segments of the population are at more risk. So thank you, Emilie, and I think we'll end here and go back to the DJ sessions. Thank you. Bye-bye.
Bye. Have fun, everybody.